Stuff has to die for other stuff to live. Are you into healthcare because like the mission? Or are you into healthcare because you're gonna make a lot of money? Why did you ignore this? Right? People died. Why did you ignore this? I haven't seen really a good systemic lessons learned. The problem with value-based care, it has brought a knife to a gunfight, but it often drives a lot of costs without getting good outcomes.
Hi, our series of digital health interviews are moving closer to the capital of the United States, Washington, D.C., and I'm super excited to introduce my today's guest. His name is Neil Carpenter. Hi, Neil.
Nice to see you.
Likewise. Let's start with your brief introduction. Tell us a bit about your journey from your early career to becoming a strategy and innovation consultant.
Yeah. So I think one of the most important things is that I started actually outside of healthcare. So in my 20s, I worked for GE, American Express, a nonprofit called City Year that Mitt Romney was the board chair of. And so I learned a lot about a lot of different industries. I also had the chance then when I went into consulting after doing that, I did a lot of healthcare, but I also did a number of non-healthcare gigs and also worked globally. So I was in Doha, Qatar, doing energy strategy. And so I think it really informs my view of healthcare that I saw how other industries work. And I think that's been a source of creative tension, let's just say.
All right. The U.S. healthcare system.
Yes.
Are you satisfied with it?
Well, I don't think anyone should be satisfied with it. One is anything that is that important and that much of a big deal has to be something you're constantly getting better. But really, right, like our costs and our outcomes are not what they need to be, frankly. And so it's hard to compare us always to other parts of the world because like some other parts of the world, people are just like have healthier habits, right? So if you're banging down the Dorito chips every day, right, like you're gonna be less healthy regardless of what the US sort of healthcare system does. Mm-hmm. So there are some real differences, but what's really fundamentally problematic in our system is we have a lot of entrepreneurship, and I didn't really talk about that, but I'm sure we will, which is great. But there's also lots of ways, once you get that many people engaged and that much money on the table, you have a lot of perverse incentives, right? Like, are you into healthcare because like the mission? Or are you into healthcare because you're gonna make a lot of money? And it's always good to have comfortable existence. And, you know, I don't want anyone to be, we shouldn't have anybody in this healthcare system who's working hard every day be poor. Mm-hmm. But when you got that much money, it's just too tempting. And right, and then there's a self-selection factor of like who's even coming into the industry.
All right. How would you evaluate the, I would say the American healthcare system response to the pandemic?
So I was deeply involved in it. I was part of the COVID task force in my state. You know, I think we did a pretty good job doing what we could. I actually think, we probably, and I'm just thinking about what my state did, the state of Maryland, I think there were some opportunities for collaboration and coordination that we failed to act on. I don't think anyone was super prepared for this. Again, our health status impacted COVID outcomes, right? So in other words, you can't take us, who is an older, frankly, kind of marginally out of shape society and compare it to a younger, more in shape society and say, oh, you had more health outcome issues. Well, COVID, how you do in COVID has a lot to do with how you went into COVID with, right? And so, and I don't know if that was articulate enough, but I think that's part of the thing we need to look at. What is a little depressing is that we spent too much money for the things we got, right? And so around the perverse incentives, right? There were just a lot of people who made a lot of money coming up with nurse staffing during the pandemic. And the question was that enough value to society to make people rich, mm-hmm. right? And that's a real open question about whether there was sort of war-type profiteering happening in the United States healthcare system during the pandemic. Because I know I was handling some contracting, the prices were rather extraordinary, right? And so we got to think about that. And while I'm really glad that some nurses were making $100 to $200 an hour, that's just also, frankly, even though it's a really hard job, just out of line with what a reasonable, like long-term structural thing would be. So we need to think about all of that. going forward. I mean, I think what's really interesting now that you are asking me about it and I have some distance from it is what I haven't seen, and I'm sorry, I'm sure someone's going to send me something out there. I haven't seen really a good systemic lessons learned. Like after 9/11, right? We had a commission and we changed things and we studied it. After the situation in Israel, they're going to study the hell out of that thing and really figure out what to do better. What I haven't seen is a real comprehensive study of how we need to have a better response and any structural efforts to do it. I think, first of all, public health itself has become a highly polarized concept, but I would just hope some foundation out there, if they haven't put it together, would put together something real to say, listen, as boring as this sounds, what are the PPE inventory levels hospitals should have, right? And can you get somebody like J-Code actually like enforce that, right? Like what is the right way to have a nurse staffing reserve to potentially some kind of version of that, then you can deploy and affect war. So in other words, if you have a war, right, you have like extra materials, you have extra people, you have extra stuff, right? And we didn't have any of that to draw for the pandemic. Maybe that was understandable because we hadn't faced it before. But there will be another one, right? Like that's one of those comments. So how are we going to deal with this? I mean, one of the things as simple as, do we need, should nations or should a state have one hotline for all information? Like I was trying to build that and we just couldn't get there. Like one way to say, I need an appointment for monoclonal antibodies. I want to know where my closest vaccine is. I mean, we had some websites and stuff like that, but they weren't actually integrated with private sources of care, right? They were just like sort of multiple systems you could kind of go to. And anyone who remembers looking for a vaccine appointment remembers how hellish and complicated that is, right? So those are systems you can stand up just like a war and flip them on when you need them. So I feel like we really do need an in-depth study of like how we design the system better. And if if leaders ignore that, then that's what just needs to happen as a record of history. So the next time this happens and we're unprepared, people are like, can wave a report around literally and physically and say, why did you ignore this? Right? People died. Why did you ignore this? And so you can't have accountability in the absence of that. So I think that'd be a good thing to do.
All right. What was the role of technology in the response to the pandemic?
I actually think we were a lot better off with technology than we would have been if the pandemic happened 10 years earlier, right? Like you could go to a website to do that stuff. I will just say, I mean, I'm going to take the kind of social media side of this equation out because that's a whole other cluster, to be honest with you, and just say it's from an operational and tactical level. I think it was helpful, but I will still say because of the speed of operations, the technology was kind of a laggard because you like literally like I was on the phone trying to cut deals and be like, hey, hospital A, if I gave you 2 staff, could you set this thing up and how soon? And people are running around, and so you're just trying to stand things up really quickly. And so sometimes it becomes, the tech almost becomes a laggard because you can do a few phone calls and actually move some stuff around in a day or two, but getting a new website up with like all the information and integrated appointments can often take longer than that, right? So I think technology was helpful in some ways, but honestly, I did not feel like it was driving operations, if that makes sense. I actually think, if I can just sort of brainstorm with you for a second, I think the really interesting part of technology is I think that could be a big part of the response, sort of the 9/11 type response to this, which is to say, we need to understand a way to get personalized and customized messages out to 300 million Americans plus, right? So in other words, imagine a world where we could have customized the messaging to say, listen, you're over 55, you have some chronic disease issues, you really need a vaccine, right? So instead of just like, you need a vaccine, just go get it, which is very simple public health messaging. Maybe we're past that age and we need very customized messaging to be persuasive, right? And people are gonna freak out being like, oh my God, it means you have medical information on anyone. Yes, if we're gonna have a unified global response to the pandemic, that means there probably needs, and I'm just brainstorming here, there probably needs to be some kind of trigger that says we're in a global pandemic, we've declared a public health emergency, and we're gonna suck up everyone's EMR data. Right? We're gonna suck up everyone's EMR data and we're gonna plug it into a customized EMR and we're gonna start messaging people, right? And we're gonna start communicating with them. And then we can do A/B testing. right? Like one of the problems with healthcare is like we are way behind on basic concepts like A/B testing around messaging, right? So we know a lot more about how to sell you soda, right? Ironically, we know a lot more about how to sell you bad things than how to sell you good things at a very simple level, right? So somebody will do an academic piece and kind of talk about some messaging and but there's not data really behind it where we can say, listen, we had 2 million Americans, we tried 20,000 iterations of messaging across these different types, and this is what was working with who and crosstab wise and everything else. And so I feel like this is a war between good and bad, and the bad stuff is winning in part because it's like more flexible and customized. I mean, social media nastiness is very well customized for you. Public health goodness is not very customized for you because we scream sort of privacy around how the government responds to public health issues. But the companies are free to gather all the information they want on you and try to message you in any way they can. And so basically what we're saying to our institutions is you have to be passive in the face of lots of problems, really. And I think that is highly problematic. And I may regret saying this, but even if Donald Trump is president, I'm okay with having him have my EMR information.
All right. Interesting. All right. Let's say you found the Aladdin lamp and the healthcare genie came out.
Okay.
What top 3 wishes you're going to ask him to improve the American healthcare system?
That's a big one. That's a tough one. First one, I would like healthcare consumers to become more educated. I think that a sophisticated buyer is the best defense. So unfortunately, when someone gets recommended surgery by a doctor, you often haven't done enough research to know whether it's appropriate or not, to be honest. You're just kind of trusting them. And we have a lot of bias. We tend to like drugs. We tend to like procedures. We tend to want to fix things, right? But it costs a lot of money, and sometimes it's really unnecessary. There's a big gray zone around a lot of procedure-based medicines and a lot of medicines. And the reality is the for-profit part of us wants to always provide that procedure, provide that medicine, patients happy, but it often drives a lot of cost without getting good outcomes. So that's one of the things that if you look at our healthcare system versus, say, Europe's healthcare system, in general, we just do more stuff and we do really costly stuff, and its cost benefit is really questionable. And there's lots of areas to do it. That's why I believe strongly in value-based care. But one of the best things we could do is have really educated customers in that. Second of all, we need to have integrated care delivery systems. And I mean truly integrated, where an insurance company, if it's covering you, really understands the care journey you need and really drives that care journey, or if the organization that's delivering that care journey is driving your care, they're also paying the premium. Our fragmented system with so many people trying to sort of serve different purposes means they spend way too much of our energy of the healthcare system is meant, to be honest with you, to capture margin from somebody else, right? And so you just don't have teams playing. And then I think the third around that would be a strong system of virtual care in this country. Virtual specialists, virtual primary care, hospital at home. And it's 2 reasons for that. One is a world of virtual care allows a whole set of new choices to people, right? Like people don't want to go to the hospital, and hospitals aren't even that safe. They're not good places to be because there's a lot of other sick people running around, right? And so however hard you make it clean, still lots of sick people in small geographic space. It's hard, right? And so when people also have the psychic desire to be at home, if you're happier, you're likely to be healthier. Like it's more socially connected. There's just a million good things, right? So, and then if you're virtually getting care, like you don't have to make appointments, you have less childcare problems, there's like lots of goodness there. But I think that's good. The great reason why we need virtual care. So payers out there, build virtual care networks. I want all my friends at those companies to, whether they're a payer or an entrepreneur, to try to build as big of a virtual network as possible. It provides competition. Mm-hmm. I'll tell you, I worked with health systems for a long time as a strategy consultant. I didn't talk about that background, but I did strategy for health systems. I did tech company startups. Is that almost all health systems won't say this, but they have a very common element of their strategy, which is they want to really dominate local choices, right? And I understand that, right? You want to make sure that you're the number one choice for care and make it really quite convenient, but the flip side of making it convenient is you're actually kind of making it hard to go somewhere else, right? That's the frank truth, right? And so what virtual care will do is say, listen, if there's one hospital network in my town, that's okay. I got lots of other care options, right? And so we need to bring competition to a local level. People think about healthcare competition at a global level, and that is true for pharma, but there's actually in some cases, limited competition at a very local level. For example, let's say you're having a heart attack. There's probably one ED that's close to you, right? Ambulance drivers, insurance companies don't have a plethora of choices. So in the ideal world, you'd actually have 3 or 4 EDs that are all equidistant from your house, right? And for which you could choose the ambulance or the insurance company or someone else would actually look at the outcomes data and then steer you to the right ED, right? To effectively punish the operations of the competing hospitals for not being as good at whatever it is, applying TPA after stroke so fast, or wait times, or anything else. We don't have a competitive ecosystem, right? And so without a competitive ecosystem, you've got lots of mini monopolies, oligopolies, and hence it's not really fair to patients, and there's lots of sort of rents in the old-fashioned economic term that derive from that. So those are at least 3. I mean, I could kind of go on.
It's going to be hard for the Genie to implement those 3.
Yes. But by the way, I mean, different people are working on each of them. It's just our pace is so painfully slow. That's my frustration. Like, I mean, I might literally die before some of these things are done. And I'm old, but I ain't that old, you know?
All right. You already mentioned value-based care.
Yep.
It's been a topic of much conversation lately couple of years.
Yes, long time.
What's your perspective on it in terms of its role in the future of healthcare delivery?
Yeah, so in my opinion, part of our problem is one of my favorite quotes are from the Untouchables movie. I don't know if I'm a little old school here, but there's a great scene with Sean Connery and Kevin Costner talking about a Chicago fight. And it talks about like, don't bring a knife to a gun battle. And it's sort of this whole litany of sort of like, you got to bring the right tool to win the fight, right? And so I think with the problem with value-based care, it has brought a knife to a gunfight, which is to say, it's kind of been working around the corners to try to do some things, which I think are good, but it hasn't had a lot of results, but it also hasn't been very radical in its ambition, right? And the reason is because fundamentally we're kind of healthcare is organized in a very stakeholder sensitive way, so that you're trying not to piss anybody off. The problem with trying to not piss anybody off is you often don't get much done, right? So I think we need capitation. So I mean, and this is one of the things I was trying to build at my own employer. I was like, listen, we will be the company that does oncology subcapitation. We will manage for you, insurance company, all your cancer patients, so we can have a lot of depth of expertise. We can have alignments with providers. We can educate patients. Like, we really own the dollar, and we're specialized enough to really manage it at clinical delivery level. I think that is the more kind of radical kind of change you're going to need. I think our incentive-based system is problematic, which is to say it's still good, but it's problematic. In other words, we'll give you $2 more for this and $1 for this and 5 cents for doing this. Those are quality incentives, but the problem is then you spend a lot of the healthcare energy and dollars trying to game that system. And we've seen that with some of the HCC coding issues, right? And so with Medicare Advantage plans. And so I'm a fan of capitation. Obviously, capitation does need some risk adjustment. Well, we really need to have a much more broad, wide open conversation about how that's done. Maybe that's done socioeconomically, maybe that's done at a group level. I mean, like, we need to think really big picture about that. But I think value-based care can work. I think, by the way, it does work. Like, other countries have figured this out, right? But other countries have a bunch of stakeholders who make less money. And so every dollar of healthcare waste is someone's income. And so that's the tough bridge we're gonna have to cut across. For there to be true reform, they will need to be both winners, entrepreneurs, other people doing cool stuff, and there will be losers, which is to say some people's income will not be as high as it used to be. We can't make everybody whole and really do new things. I mean, it's just like the government printing money. The government wants to write everyone $1,000 checks. If there's no increase in productivity, it just leads to inflation. Everything that happened in this country in the last 4 months or a couple of years around inflation, very predictable from an economic 101 textbook. You printed a bunch of money, you ran big deficits, you ran extra checks out, and then suddenly more dollars were chasing the same amount of product, and so you just had inflation. And so we have a little bit of that mental hiccup on healthcare where we just want to print more money, have more stuff being done, not think about what's going to get taken away, and suddenly have and think it's going to work. So for example, when we do value-based care, we will then need less healthcare services. When we need less healthcare services, it means we're going to have to close capacity, right? That means a hospital wing closes. That means a hospital closes. That means an ED closes. That means a physician office that's physically present today closes as you go virtual. Stuff has to die for other stuff to live. And so we're like trying to plant a garden and not weeding out anything because someone's going to get pissed off politically and economically. And so that's what I really want to see happen. That's why we need a knife, we need a gun at the knife fight.
Who can bring that gun?
I think payers today have the capacity to bring that gun. I think employers today have the capacity to bring the gun. I think government today has the capacity to bring that gun. I think what the payers need to do is get clinical. I mean, they're getting clinical, but I think they need to get more clinical so they can take control of the care journey more forcefully. I think governments are going to need to be more radical. You know, a study just came out saying CMMI cost money, didn't save money. And I think it's fundamentally part of the challenge of trying to run very limited experiments and their political environment. So I think those are just two entities who can go out and make this difference, you know, and a healthcare system, you know, can go out and decide we want to be a payer potentially and be more integrated and deliver and really change things.
Okay.
But it takes risk.
Right.
It means real risk. Yeah.
Let's imagine you've accepted a job offer as a chief strategy officer in a healthcare company, which use the fee-for-service model, but then the management is feeling like they want to switch to value-based care model. Like, what would be the key points for organization to consider in order to do that transition?
So one is, and I hear this from a lot of my friends working on this stuff, you know, is that they're working on very basic stuff around workflow at the provider level to make sure you can kind of enable that you've done the med reconciliations, that you've scheduled them for the right appointments, that you've done the right kind of outreach follow-up. So I think there's a bunch of basic stuff that people are still working on, which I think is super important. But I would also say it means your system has to be aligned in a way for value. So in other words, if you look at the workforce we have, our workforce doesn't look like other countries' workforce. We've got a lot more specialists doing a lot more specialty stuff and a lot less primary care docs. And so that means you fundamentally need to align your workforce in a different way. So you need tech in a different way. You need real clinical pathways, right, that are very defined around value, right? And you need to operate that way. So the bottom line is, you know, you're going to have less choice as a doctor under a value-based care service than under a fee-for-service system. You just simply have less degrees of freedom. And you can ask anyone at Kaiser about that. Like, that's just true. And it's true in any heavily clinical pathway formation, you're gonna have less choice. And so that brings me to another question, and I'm gonna digress for just a second if you'll indulge me. So part of the thing that's really important is our healthcare system operates under a lot of degrees of freedom for individual clinical actors. I mean, you don't want to get sued, and they're trying to do the best thing for the patient, and they're really leveraging their years of expertise. But it's really an apprenticeship model, like old-fashioned, like I learn an art from somebody before me, and then I go practice that art. But if you look at other industries, they're highly regimented in their approach. So in other words, an average person in the healthcare system today has more professional degrees of freedom than in other industries that have basically turned people more into cogs, right? The data, like, you know, if you want to determine your schedule and you work at a Best Buy, the computer's deciding when people are working and what shifts. Here we tend to have more human decision making. Human decision making is costly and harder to learn from, because Best Buy then say, well, we've run the algorithm and we can see in these kinds of stores where we ran this scheduling protocol, we had 2 cents more per sales than these other stores. And so we're going to run it that way. And so we need to industrialize our healthcare system and make it very data-driven, not just with A/B testing of patients, but A/B testing of how providers are managed, A/B testing of how people are scheduled, A/B testing of how they do their work, right? So imagine every doctor recording everything they do, running it through the algorithm, learning from it, and then improving it. So there might even be a lot of customization of how we communicate with patients. This is how you talk to this kind of patient. This is how you talk to that kind of patient. It will lessen your degrees of freedom, but it will allow us to have a learning ecosystem that other industries adapt, right? So those are some of the elements of things that would have to be done. So you need the data infrastructure to run value-based care. You're going to need to realign your workforce. And of course, you need incentives and a financial model to support all those things.
Finally, what kind of piece of advice would you give to startup founders in digital health in order to be successful?
Yeah. So unfortunately, I would give them a lot of advice. Sometimes I probably give them too much advice. Ask the companies I work for. I just was texting them. I'm like, no, we got to do this. So I unfortunately, I'm like a very opinionated. I'm 50 years old. I've been in healthcare a long time at like lots of different levels. So I have a lot of opinions. I think the core one I'd leave, which I actually just heard at a Rock Health Forum the other day, which I wholly agree with, which is like be really prepared when you talk to companies and when you know a space to just really know it very well. I mean, I love the energy of some of these young entrepreneurs, but they just simply haven't worked in the system long enough, and they don't have enough time to do enough homework on the people they're going to talk to. So to know your space cold and do homework on all the people you want to work with and make sure that things are really lined up, or otherwise we waste a lot of their time and your time trying to find out if there's a match. That'd be one example. Yeah.
All right, I totally agree. Really good advice. Thank you, Neil, for all your insights.
Great conversation, man.
Pleasure talking to you.
Yeah.